Good afternoon, everyone, and welcome to this webinar organized by the Collective for Political Determinants of Health. The Collective, if you don't know it, is dedicated to advancing research on how power relations, institutions, interests, and ideologies shape health within different political systems and cultural contexts, and across different levels of governance. My name is Katerini Storeng, and I co-direct the Collective, as well as being Professor of Medical Anthropology and Global Health here at the University of Oslo. So ordinarily, this conversation series features members of the collective, but today we are going to be introducing some emerging scholars who are affiliated with the Global Health Politics Non-Resident Fellowship at Boston University, which is led by collective member Joseph Harris. Joe is not here today. He's off celebrating his birthday, so happy birthday, Joe. But before we introduce you to our chair and speakers, I just have a few points of housekeeping to go through. The speakers' presentations will be recorded and made available online after the event. However, the Q&A session afterwards is not recorded, so you can speak absolutely freely. Audience members can ask questions either by using the Q&A function in Zoom or by using the raise hand function and asking their question directly. And if you wish to stay up to date about our future events and other activities of the collective, please sign up to our newsletter and follow us on LinkedIn. And these links are going to be posted in the chat shortly by Emma. So I'm now going to hand over to today's chair, who is Jane Pryma. And Dr. Pryma is a sociologist of health and medicine at BU at Boston University, who explores how political economic systems, medical technologies, and cultural beliefs about rights shape how we understand pain, disability, and our obligation to care for one another. And you will be able to read all about this in her forthcoming book, Pain Points on Opioids and Right to Pain Relief in France and the United States, which will be out in March with Stanford University Press. But Dr. Pryma is here today because she's also Associate Director of the Global Health Politics Workshop at BU, which she's now going to tell us a little bit about before introducing our speakers. So I will therefore hand over to you, Jane, and look forward to hearing about your program. Thanks.
Thank you so much, Katerini and Emma, for hosting us and inviting us to be part of this really exciting collective. So I am here today to introduce our really wonderful speakers who have been part of our last cycle of non-resident fellows in our Global Health Politics Workshop Fellows program. But I'd also like to give you all a little bit of a taste of the Global Health Politics Workshop that we run housed and sponsored by the Party Center for the Study of the Longer Range Future at Boston University and directed by Joseph Harris. We really encourage you to join us on our usually monthly during the school year presentations of a really absolutely fantastic rotating cast of speakers. So I've included a QR code on this PowerPoint slide. You are welcome to sign up to receive our updates about upcoming events. On the website, you'll get a lot of different rich information about the Global Health Politics Workshop on the website. But the monthly Global Health Politics Workshop series brings together leading social scientists from the disciplines of anthropology, political science, and sociology, along with practitioners in Boston and around the world, to advance understanding of health phenomena in a globally connected world. The workshop operates in hybrid format to accommodate participation in person and via Zoom, and seeks to create a framework for the exchange of ideas across disciplines and borders. And we really do encourage you to join us in our programming. In the fall 2026, we meet once a month, Mondays, from 4 p.m. to 5:30 p.m. Eastern Time in the US, which I know can be challenging sometimes for different time zones. But again, we would really encourage you to join us if you have a chance. And you can see on this slide the absolutely fantastic speakers we had this past spring as part of the workshop. We also put out a podcast associated with the workshop. You can also find a link to the podcast via the QR code to our website and take a listen. It's a really fantastic collection of conversations led by Professor Harris between leading scholars and practitioners in the global health space, discussing the challenges and joys of kind of working in global health in today's landscape, and giving more of a kind of inside look at the work and scholarship and research process behind some of the books and research products and policy work that I think we all are familiar with and quite interested in. And finally, the reason we're here today is our Global Health Politics Fellows Program. I put up on the screen our wonderful fellows from last year. We have just completed selecting the fellows for the 2026-2027 cycle. And again, if you take a look on our website with that QR code, you'll see that there was recently just put up an announcement announcing our cohort of fellows for this upcoming year. So it is my great honor to get to introduce two of those Global Health Fellows today. First, we're going to start with Mutiara Indriani. Mutiara Indriani is a PhD candidate and Australia Award Scholar at the School of Regulation and Global Governance, Australian National University. She applies an interdisciplinary approach to explore how political economic conditions contribute to COVID-19 vaccine access in Southeast Asia. Her research focuses on the interplay of institutional, ideational, and actor interests in Indonesia, Singapore, and Thailand. She holds a Master's of Arts in International Relations from Leiden University and a Master of Science from Uppsala University. She is a 2025-2026 Global Health Politics Fellow at the Frederick S. Party Center for the Study of the Longer Range Future, Boston University. Her broader work has engaged topics of regional political determinants of health, pandemic preparedness, and health equity. So please join me in welcoming Mutiara Indriani to present her research on regional political determinants of health. I'm going to hand it over to you, Mutiara.
First, let me put up my slides for you. Yes, there you go. I hope that everyone can see that, and thank you for joining today. Thank you so much, Jane, for that warm and generous introduction, and to Katerini and the collective for letting me share these reflections. It is really such a joy to be able to have this conversation with this group in particular, because I have been so inspired over the years by reading many of you and listening to many of you. Since last year, I'm with the Global Health Politics Fellowship, and coming from Southeast Asia, I have the privilege of working with experts on regional governance in Latin America, Africa, and Europe, co-authoring a part of a Lancet series on the regional political determinants of health. This spurred me really to think more deeply and do what is not done very frequently in a PhD journey, which is to push the conceptual boundaries of the political determinants of health and identify where regional arrangements are addressing risk or gaps left by national and global level, and which institutional approaches might be worth adopting elsewhere. So our work is part of series with common conceptual framework and definition of political determinants of health. Here, a working definition of political determinants of health is a factor pertaining to governance that shapes the distribution of power and resources at local, national, regional, and/or global levels, with consequences for population health. The central concept in this definition is governance, by which we mean the mechanisms states and societies use to pursue collective goals and enforce rules. Governance mechanisms do not always produce socially beneficial outcomes. Some may advance population health, while others may harm health. Governance mechanisms are shaped by interests, ideas, and institutions. This is why it is so important to understand how these governance factors play out using the multi-level governance approach. And this is why the Lancet Public Health series on the political determinants of health has 4 ongoing projects, with this talk representing the regional level. So our team is focusing on developing a manuscript on the regional determinants, and this work is still ongoing. We noted that regional political conditions are consequential for population health. Although it is much less well appreciated, the social construction of health and health policy is also defined by global and regional factors that are political in nature and are the product of concerted human efforts. We noted that concern with systematically understanding deliberate projects of cooperations in world regions that in turn have impacts on health outcomes, health systems, and health policy is much more nascent. Through an inductive examinations of regions and the existing literature on regional political determinants of health, we are trying to surface and make feasible what these regional projects look like and the different forms they take in different world regions. We also need to take seriously the variations between regions concerning health cooperation. Further, from a broad scan of relevant literature, we found only 171 articles, with none explicitly using the term regional political determinants of health. At the time of this presentation, we are not aware of any work out there yet that conceptualize regional contributions to improving health and mitigating harm in terms of regional political determinants of health. So the regional space is very important to understand how and why some determinants of health are very different from those determinants of health found at the national and the global level. Initially, we think regional political determinants of health as a collective actions. These are initiatives that are purposefully formed by and within a region to improve health and mitigate harm. It may have direct impacts on health, such as regional pharmaceutical autonomy or mechanism for managing transboundary health risks, and indirect effects on health, such as diplomatic power and social rights regimes. So whether formal or informal, regional arrangements shape and reshape power and authority across a geographic area shared by multiple states. But this agentic framing is not enough because some regional conditions clearly impact health without being designed to improve health or mitigating harm. Structural issues can shape health in their own right, while human action or inaction can sort of move health outcomes in either positive or negative directions. So we are now reframing regional political determinants of health by incorporating both agentic and structural terms. As seen in the chart here, we try to identify concrete examples of action, organizations, networks, and regional mechanisms that seek to address these regional issues. This includes, for example, regional capacity to respond to disease outbreaks and regional security or peacekeeping arrangements. The social determinants of health literature also informs our approach, especially its attention to proximal and distal paradigm and to the pathways through which determinants travel across levels. We are not trying to reinvent the wheel, rather we build from it by treating the regional level as a distinct social space. This helps us understand how regional determinants should not be seen only as an enabler of health. It can also be a zone of risk and a determinant of ill health. Another dimension is regional political economy. Regional trade, investment, competition rules, fiscal governance, and value chains can affect health both directly and indirectly and can affect health negatively as well. Because regions are shared political and economic spaces, the negotiations that occur within them can have fiscal elements in ways that differ from both national and global processes. For example, everything from common tariffs to collective positions at the WTO. So our framework distinguishes several dimensions that shape regional political determinants of health: authority, governance and legitimacy, financial and political economic capacity, political coordination and implementation capacity, mediating factors, patterns of vulnerability and insecurity, and norms, values, and political purpose. The influence of external actors and powers, together with legacies of coloniality and dependency, is also central to our thinking. Regions vary in the extent to which they depend on foreign assistance and in the resources available to them. These patterns of dependence can create structural inequities, affecting both a region's capacity to mount security response and the degree of autonomy it can exercise. Colonial and neocolonial legacies matter in cross-border dynamics in Africa and Latin America, where borders were often arbitrarily drawn. These histories may help explain why cooperation emerged in some settings but is limited in others. Regional responses to outbreaks must also be understood through the history of region making, border making, and political relationships that shape who is responsible, who has the authority, and how solidarity is mobilized, such as in the case of Ebola. Further, regions are composed of states with colonial histories, but coloniality also affects how regions understand and organize themselves collectively. In Africa and Latin America, we see that um, collectively in Latin America, these legacies can give regional cooperation a particular flavor and direction. This makes the regional level distinct from the national level, while also demonstrating that regions cannot be treated as a vacuum. We note that some of these factors may be conceptualized as regional political determinants in their own rights. Others may be better understood as contextual conditions that shape how regional determinants emerge and operate. So there will be an article published soon that goes through the arguments that expands on some of the things that I have spoken about today in order to unpack and measure the pathways in which regional political determinants travel and their health impacts. We need to expand its conceptual boundaries and make sure that these concepts remain applicable to policy and practice. And as I will finish my PhD by mid-2027, I would very much welcome any opportunities to carry this work forward. It's been a pleasure to speak to you all, and I look forward to answering your questions. Thanks.
Thank you so much, Tia. All right. I think we're getting slides up. So it is now my honor to introduce Tiago Tasca, who is a Chancellor's Postdoctoral Fellow at the University of California, Riverside. His research sits at the intersection of comparative politics, public policy, and political behavior, with a regional focus on Latin America and Brazil. His work examines how political polarization, misinformation, institutional trust, and state capacity shape public health policy and citizen behavior, particularly in the context of primary healthcare. So today, Tiago is presenting When Capacity is Not Enough, Political Incentives and the Selective Activation of Preventative Health in Brazil. Please help me welcome Tiago Tasca.
Thank you. Can you see my slides? I
I
can
can see them. Yes.
Great, thank you. So let me time myself. Great. So thank you, Jane, for this wonderful introduction, and Katerini and Emma for organizing and put together this space, such an important space for us to talk about politics and global health, the political determinants. It's a very valuable space, especially nowadays with the current challenges we've been facing. So I'm very grateful for this opportunity. And I will talk about today on my project and that I hope to become a book in the coming years on Brazil and immunizations in Brazil. For many years, Brazil had achieved very high immunization rates and it's worldwide known for its public health system free at the point of use. But despite this very great hallmarks in terms of healthcare, vaccination rates have been declining starting in 2015, which is before the pandemic, which is a common explanation for declining immunization rates worldwide, and also before the administration of Jair Bolsonaro, which is well known a vaccine skeptic and also widespread a lot of misinformation in terms of vaccination, right? So the question that I'm posing here is also to understand the subnational drivers, right? So we are going from the regional determinants, the global level to very local level. This is the explanation I'm trying to offer here is that there's a lot of subnational variation in terms of municipalities in Brazil. And then the question is really if capacity exists in Brazil, right? Brazil had vaccinated its entire population for years. So why does prevention fail in some places, but not in others, right? While some places have been able to achieve high immunization rates, others have experienced a sharp decline. So what explains this? Right. And I'm taking here a supply side explanation, looking at the state-led resources, human resources, and also public investments. I'm not saying that individual level explanations such as vaccine hesitancy, they're not important. But in this case, I'm looking to the state part of the story, while the demand side is also a part of another big project I'm carrying on. So oftentimes when you look at the state, we tend to argue that the political will, right, is the lack of political will, state inaction. But we need to qualify what does that mean, right? What are the political incentives? So I'm taking these provocations and questions and relying mostly on political science literature, on state capacity, not only the capacity, the organizational infrastructure in place, but how is that deployed toward a specific primary health care and policies, and also decentralization. When you look to the local level, the discretion local leaders and health officials they have to implement and carry out policies, public health policies. So the main argument is, of course, politics matter. This is why we are all here to talk about the political determinants of health. But preventive services, primary health care, they're long-term efforts, right? They need to be sustained over time. And because like a good or a successful preventive healthcare policy is the absence of crisis, right? When the population is vaccinated, you don't have outbreaks. And it's hard for politicians to really claim credit for something that is not happening, right? So for this reason, politicians, they have the incentive to really invest in curative, more visible healthcare policies, such as specialized doctors, inaugurating hospitals, and hiring more open more fancy clinics, for example, right? So they redirect the infrastructure in place for primary healthcare towards curative care, right? So if that logic held unconditionally, we would experience a decline all over Brazil. But that's not the case that I argue here. In some municipalities, preventive services, they can generate constituencies that make underinvestment or even retrenchment of primary healthcare really costly, politically costly for local officials. And this is why they keep investing in primary healthcare, and the constituents are really pushing in this self-reinforcing mechanism that keep immunization rate really high. I want to put your attention to community health workers as a really great proxy for understanding the prioritization for primary health care, because they conduct home visit, right? They knock people's door. Hey, let me see your vaccination card. And then remind people to get vaccinated, right? And they are central for vaccination, especially right now in the era of misinformation. They really help to build trust within communities and to build the link between the health system and population. But this work is largely invisible, right? In contrary to like a hospital, as you can see in the pictures, that you can, take pictures, post on social media. like the work of health agents remain largely invisible, and they can easily be repurposed to curative services. So the expectation I have is municipalities with higher density of health agents and deployment toward primary healthcare should display higher vaccination coverage. And I analyzed this and answered this question using a mixed methods research design, combining interview and original administrative data, combining over 1,000 municipalities, and also two case studies here. So let's go to the findings, right? Unsurprisingly, I found that higher density of health agent is correlated and associated with higher immunization rates, right? So they really matter. But the really important thing here, and you can see here, like they across all models, they really matter. But the really important thing is how are they deployed? So I'm departing from two case studies from two municipalities that they have a similar level. They are like higher than the threshold recommended by the Ministry of Health of community health agents. So they have the minimum, and how they're deploying those health agents is what matters. So in Janice and Cerqueda, what we see is capacity without activation. So they have the capacity in place, but both the administration that changes every 4 years and the population, they don't really value the work done because it's largely invisible. So because both constituents and the administration, they don't see preventive as something to push forward. They repurpose health agents to triage, administrative work, and even driving, right, to drive population around. So because of that repurpose, what we see is a decline in immunization rates in that municipality. On the other hand, in Tigrinhos, which we see prevention as the policy legacy, health agents, they remain embedded in community life, right? They're part of like community parties. They have constant contact with the population, and the population really trusts them, right? So over time, both the local administration is committed to prevention, and the population also see this role, prevention important, right? Just one example that I heard while in the field is that many people, they see, they experience a reduction in insomnia medication or even hypertension medication because they're following more closely the preventive guidelines issued by the local health officials, right? So people becoming to demand more prevention, and the administration, because the politicians want to get reelected, and they follow the constituents' desire for more prevention. And in Tigrinhos, you have an amazing wellness center with a pool, chromotherapy. So over time, more and more preventive services are offered to the population. And you can see here that Tigrinhos never in the red, never really experienced a decline in immunization rates, in contrast to Janice and Cerqueda in the blue line here. So the question that I'm putting forward in the coming months is when preventive routines become visible enough to generate citizen expectation, right? And then political protection, because politicians, they will not dismantle if they perceive that this will hurt their chances of stay in power. So clearly a political and power analysis of what's going on in the field. And to conclude, I think the main lesson here is Brazil vaccination decline is not a story of administrative weakness, right? Oftentimes we explain health outcome or underperform of health outcome in terms of lack of state capacity, right? That's not the case in vaccination rates in Brazil, right? It's how subnational governments deploy the capacity they already possess. So long story short, capacity is necessary to achieve great health outcome and improve people's well-being, but it's not sufficient, as I argue in this paper. So I'll stop here and I welcome your question. Thank you so much.